Welcome to the DNA Talks podcast, where we take on the mission of unlocking the code of your genetics. This season is all about you, upgrading your health, not just on the surface, but down to the root cause. Join us as your clinicians at the DNA company investigate your DNA and beyond. The intention of this podcast is to enhance your lifestyle by changing what is in your control. This does not substitute the medical advice given by your personal doctor, therapist, and other healthcare professionals.
Welcome to another episode of the DNA Talks, where we dive deep into the science of optimizing your health through genetics. And today's guest is Dr. Mark Gordon, a world-renowned leader in neuroendocrinology and brain health, here to explore how hormones may hold the key to treating Alzheimer's disease. From groundbreaking protocols to the latest in genetic insights, we're about to uncover how you can take control of your cognitive future. Stay tuned. It's going to be an eye-opening conversation. Dr. Mark Gordon is a trailblazer in the field of interventional endocrinology and traumatic brain injury, aka TBI. A New York native, now based in Texas and California, Dr. Gordon initially trained in family medicine before expanding his expertise into clinical orthopedics and sports medicine. And back in 2003, he coined the term interventional endocrinology, shaping standards best in class for anti-aging and hormone replacement therapy with his groundbreaking book, The Clinical Application of Interventional Endocrinology. Dr. Gordon is also best known for his pioneering work in linking TBI to hormonal dysfunction, a subject that he's discussed on multiple episodes of the Joe Rogan Experience. And his innovative Millennium Treatment Protocol has gained national and international recognition, including from the UK's Military Surgeon General, for its success in treating military personnel. He is the medical director of Millennium-TBI and CBS Studios, and his latest achievement is the development of an AI-powered diagnostic tool that allows healthcare providers to replicate his expertise in TBI treatment in just 15 minutes. You'll hear from him all about that next. Through his extensive career, Dr. Gordon's also been featured on major networks such as HBO, CNN, ESPN, and he remains a passionate advocate of optimizing brain health through neuroendocrinology. He's also, by the way, prominently featured in the Netflix documentary Quiet Explosions: Healing the Brain. For his groundbreaking work on the TBI and, of course, PTSD, or post-traumatic stress disorder recovery, highlighting the profound impact of his methods on veterans, athletes, and civilians alike. Dr. Gordon, is an honor and pleasure. You are the go-to when it comes to all things brain and neuroendocrinology. And I can't believe I said that without stumbling too much. It's like a real tongue twister, mouthful, neuroendocrinology. You know, we are both.
Thank you.
Thanks so much for having for having the time and spending the time with us.
Anytime for you. I love our dialogue. It's just dynamic and expands my brain. It lets me know how much I don't know.
Well, we're going to talk about neuroplasticity because talking to you, I feel like I make, a couple of 100,000 new hippocampal neurons every time as well. And we're both pretty deeply entrenched in this evolving world that we like to affectionately refer to as functional medicine, right? Kind of a trendy medical buzzword of the day. Maybe originally was called alternative and then became complementary alternative, then evidence-based. Functional, but your work spans patient consultations, groundbreaking research in hormone therapy and brain health, public speaking, writing, collaborating with veterans organizations to treat TBI. You've just come from the White House we were speaking about off camera. And of course, while I focus and serve as co-founder and chief of innovations at the DNA company, beyond and don't do nearly as much as you do, but beyond this sort of professional overlap, we share this personal experience with Alzheimer's. Your mother, may she rest in peace, and my own, who is currently in very late stages of the disease itself, is in long-term care. She doesn't know who I am, and it's a sad state of affairs. We have to do better. If we could even just start there, like let's dive right deep into the novel concept of neurosteroids, neuroendocrinology, and this cognitive decline. And by the way, your upcoming talk, which you'll be giving at the 37th Clinical Applications for Age Management Medicine conference, and I believe it's Salt Lake City, Utah. It explores these neurosteroids and their impact on Alzheimer's, and you've titled it actually Alzheimer's Disease, a Hormonal Approach to Treatment. Tell us all about this.
Yeah. Well, we've had the burgeoning illness of Alzheimer's disease since the 60s. And the treatment that has been developing over those years has done very little, because I don't believe that we really understand the neurobiology that's behind it. We assume certain things like
Right.
genetic predisposition because of the ApoE4 gene. We know that there's APO1, 2, 3, and 4, and uniquely 4 is the one that's associated with the predilection for generating the key protein that creates the disease called beta amyloid or amyloid beta. But we don't look at why the brain is generating the beta amyloid. We've thrown in, to make it more convoluted, the presence of tau protein and neurofibrils, which is from tau protein, which is part of the conduit in every neuron, the neurotubules or the microtubules of the cells that transports the neurotransmitter acetylcholine down its pathway. And that was the premise for why certain medications, 2 medications came out to try and enhance the amount of acetylcholine by stopping its degradation. But it turns out you're not making the acetylcholine. That's why the product doesn't work. And when you
Right.
look deeper at the premise of what's going on, I mean, I've got a paper that's pending which looks at multiple sclerosis, Alzheimer's, traumatic brain injury, and Parkinson's disease. They all have similar foundational issues. Inflammation being number one. If you look at the genetics behind Alzheimer's disease, only 5% of it can be associated with the ApoE4 gene. 95% of it is spontaneous or sporadic forms. And when you
Right.
start looking at the science of sporadic generation, you see 2 things that are associated with developing the 95%. 1, aging.
Mm-hmm.
2, history of trauma. So then going back to what are the similarities or what occurs in aging and in a trauma that can create the environment in the brain for predilection for tau protein and beta amyloid. And it's this neuroinflammatory cascade. From the longer we live, the more exposed we are to traumas. People think
Right.
trauma is just being hit on the head, but
Right.
it's nutrition. It's our epigenetics from things that we've taken in that are causing our genes to try to modify. It's mutation of our genes from all the crap we're taking into our system. And these generate the inflammation that sets up the foundation for everything that we'll eventually talk about.
And I've heard you say before, and it's usually the opposite argument that us in functional medicine are trying to make, where disease impetus or underpinning or underlying cause of disease is so often, made to believe biological in origin, and then sometimes we're good enough in functional medicine to make the case that it's actually stress that plays a role. Well, I hear you always defending this in opposition, maybe even counterintuitively for most, where this trauma we're talking about, PTSD is one major example, post-traumatic stress
Now you
disorder,
got me started.
is not just psychological
Correct.
or cognitive. This is a biological issue. And by the way, I know you believe, as I do, our good friend Dr. Dale Bredeson's going to win, a Nobel Prize at some point, right? The way he subfractionated all these different subtypes of Alzheimer's. But if you would, because I've also heard you talk about this, first describe why ApoE is somehow evolutionarily, because by the way, I fall back heavily on evolutionary biology when I really want to understand something. Like, why is it here in the first place, this gene? And at the DNA company, we actually we don't even report ApoE in context of cognitive decline and Alzheimer's. We report it in context of cardiovascular health, because the age-old argument of cholesterol and even fraction and size particle, it's inflammation that warrants the deposition of cholesterol in the first place. So we look at all those inflammatory genes and ApoE and that cardiovascular link, which is only just one of which is beyond that 5%. So why is ApoE still in our genetic aptitude?
Yeah.
And maybe even how might we use key hormones? And you talk about like pregnenolone, testosterone,
Right.
to help slow or even reverse cognitive decline, like bring all of that kind of
Yeah.
full circle.
Well, as I said, there's APO 1 through 4, and 4 seems to be the one that can induce a lot of beta amyloid being formed. So it's a trigger for stimulating other components that create the inflammation, because the NFTs, the neurofibril tangles that are produced from the tau protein, tau hyperphosphorylation, is what creates the inflammation. And you're right, it also influences the heart, the ApoE, but it influences all the body.
Right.
It's what organ or organ systems are more susceptible to the level of inflammation. How much protection do we have already in play? It's like in the group of people that I work with the military, I have a team of guys who are exposed to the same explosion. Why is it that some of them develop symptoms and others don't? Genetic predisposition, lifestyle seems to be a very heavy participant in it. Alcohol, certain medication, nutrition, hydration, sleep, gut health, and all these things play a role in diminishing the built-in Kevlar, I call it, the protection that each of our organs, a brain, and so forth has. And we whittle it away, we thin it out so we're more susceptible by things we do that are negative to strengthening our body, alcohol being probably the number one. So how does the pregnenolone, the allopregnanolone, how do these hormones, neurosteroids, influence the outcome of these inflammatory conditions? Well, it turns out that all our hormones are called pleiotropic, meaning they have multi tiers of benefits. So if we were to take something like we spoke about earlier, estradiol has a built-in piece of its structure, which is a free radical scavenger. So what did we learn? We learned that radicals, free radicals, oxidative stress, oxidative load, turns on the cells in our brain, the microglial, the immune cells of our brain, and allows them to become activated. And when they're activated, they start producing, through a multitude of cascades, pro-inflammatory cytokines. And these pro-inflammatory cytokines do what we spoke about on the sideline when you were talking about L-tryptophan carboxylase, L-tryptophan dehydroxylase or hydroxylase, which are the enzymes necessary for us to make serotonin. Well, inflammation will knock down those enzymes, so you can't make serotonin. If you can't make serotonin, you can't make melatonin. That's why 100% of our patients, our military that come into us, what do they have? Depression, insomnia, fatigue. And it's because of the deficiency due to the inflammation. A specific reactive nitrogen species called peroxynitrite, which is built off of reactive oxygen species, ROS, and nitric oxide. So it steals the nitric oxide, which is a signaling molecule, as well as a very important vasodilator. So when you do a PET scan, you can actually pick up areas, or a SPECT scan like Dr. Amen does. You can actually pick up areas of the brain that have had the nitric oxide stolen. That's the reduction in blood flow, and that's what we see in the SPECT scan is punched out areas.
Right.
So the benefit of these neurosteroids is that they have the capacity to modulate our immune system. Testosterone is the best.
That's the name of the game, isn't it? Not driving down, depressing, suppressing, but immunomodulation, because neuroinflammation, as you preach, is often cited as the driver of Alzheimer's progression. But what I heard you just say there a moment ago, which really struck a nerve, I want people to understand this and hear it again. Coming into a trauma, be it physical, mental, emotional, in a state of, this is why inflammation is a medical buzz term of today. If you're in a pro-inflamed state and then you experience trauma, the chances that trauma actually has a significant or more than your body's able to maybe recover. Sleep, we should get into that as well, and
Right.
talk about lymphatics and why the brain does what it does only given the opportunity to sleep deeply. But you're predisposed in that state of inflammation, right? Going into a trauma. That's going to be and then some of that is driven genetically, but so much more is driven from our environment, our neurotoxic exposures, the nutrition that maybe we eat or don't eat that ultimately acts as antioxidant, anti-inflammatory. Am I right?
Absolutely. absolutely. You know my daughter Allison well. That's how
Yeah.
we eventually originally met. She has been taking care of not only the civilian population with TBIs, but she moves into my military to take care of their gut health. What we
Right.
found is that if you have gut problems, that we can't fix the inflammation in the brain fully. So they have lingering symptomatology. Why? Because that constant flow of pro-inflammatory, the inflammatory chemistry from the gut goes into the brain, turns the brain's inflammation on. So
Right.
you go from maybe acute. I mean, one of the issues is an acute trauma and a chronic, acute inflammation and chronic inflammation. Example of an acute inflammatory process is a cold. You get a cold, you feel off, you're fatigued, you headache, you're irritable, you don't want to eat, you just want to lay in bed, you got body aches, and then you get better. But in chronic conditions where you're constantly generating that inflammatory chemistry, it doesn't subside.
Right.
And you need to look in the gut. So we found people were chronic, going, persistent, even though they were on treatment. She found the gut, fixes the gut, they get better. So talking about lifestyle and gut, but going back to the neurosteroids, which are the hormones produced in the brain by our neurons, our oligodendrocytes, all the cells in the brain make the hormones. And it's in my presentation on Alzheimer's disease, the hormonal approach to treatment. And what happens is inflammation, regardless of how you get it, inflammation shuts off the ability of the hypothalamus, the area that controls a chemical called gonadotropic releasing hormone, that goes to the pituitary and says, hey, make luteinizing hormone, make follicle stimulating hormone. Follicle stimulating hormone in men turn on sperm production, in women, oocytes, egg production. The luteinizing hormone goes to the Leydig cells in males, goes to the thecal cells in females to generate our hormones. But when you have any form of inflammation in the brain, that process is shut down. And we're seeing it right now with people who have had the recent infection pandemic.
Right.
Okay.
Right.
A
Well,
lot
and
of
I really appreciate
infertility.
that you bring so much back to the brain because I think, even in functional medicine, I think a lot of practitioners jump too quickly. I mean, of course, we all appreciate there's a distinction between hypogonadal presentation. That's
Right.
in the literature and the textbooks, typically why a conventional doctor might give somebody hormone replacement therapy, particularly a guy, until at least the Women's Health Initiative came out with this new information the last couple of years. But my point being, is so much of it starts in the brain, not just mental, emotional, inflammatory predisposition leading to downregulation of those centers you described, physical, obviously included. But if we talk about brain down, it makes no sense to just simply slot in any of these hormones, whether they're, master hormones like DHEA or progesterone, pregnenolone, downstream problem, right? So give us a little bit of an idea, because this is your area of expertise. How do we even identify a patient who's got hormonal dysregulation starting in the brain that could ultimately lead to Alzheimer's progression, but also
Yeah.
to just general poor health, brain
Yeah.
fog, energy depletion, just like
Great.
lack of ability to sleep?
Yeah. Great, 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 great question. And it's one that I've been trying to work to hone down to a nice, simple answer. We use a 28-point biomarker panel. Now, understanding, I've been in laboratory science for a long time, medical director of education for a laboratory in Florida for the past 16 years, but before that with Quest Labs, SmithKline Beecham, and whatever. So I cut my teeth on laboratory science and understanding how the laboratory hormones, we'll talk just hormones, how the hormones interact with each other. It's like we know, as I just said, that if you have trauma and you have inflammation in the brain, what gets influenced is LH and FSH. But most people go after, most healthcare providers go after the testosterone level. They look
Okay.
at the total testosterone, which is worthless, because if you really looked at what total testosterone is, it's a lot of pieces of, possibly garbage and possibly 2% that you can use. But looking for free testosterone tells you what you have available that can go into the brain, because it's the free form that can pass into the brain where it gets converted into other hormones, as well as, the androgens that are produce from it DHT, 3-alpha androstenedione, estradiol, estrone, estriol, and so forth. You can look at the patterns. So if you have someone has a car accident and they're 28 years of age and they have a level of luteinizing hormone and follicle stimulating hormone that's like an 80-year-old, and they have a corresponding drop in their testosterone level, and they have a history of a trauma, the correlation is there. Can I categorically say it's absolutely that? No, but it's the best thing on the table, okay? Another issue is thyroid. Dysregulation of the thyroid, there's something called the Jostel index, which they commonly call the TSH index. It's a mathematical model. You can do the calculation on it, very simple. TSH and T4. If the number comes back at 1.3 or less, it means that dysregulation of the thyroid is due to the brain. If it's greater than 4.1, it's a problem in the thyroid gland, whether or not it's an autoimmune thyroiditis, Hashimoto's, Graves' disease, or selenium deficiency, or iron deficiency, or B12, B6, and B9 deficiency, or elevated levels of cortisol, which increase the production of reverse T3, which in and of itself is a whole hour-long conversation on thyroid and thyroid. So anyway, what we use is the AI platform. It took me, my background was computer electronics. My father gets bone cancer, ex-Army, and dies from it. And that's what threw me into medicine. I kept my finger in the computer world, programming, and spent the last 10 years, wrote a software package, which takes the 28-point biomarker panel and analyzes the laboratory results. And it looks at these patterns. We as physicians, healthcare providers, were trained in line by line, like an accountant. Oh, this test is normal. This test is normal. This one's low. This one's borderline. This one. But the software interacts or interrelates all the labs. So it's 28 to the 28th power of interactions. It's a 12-page report. And it tells you not only where the medical conditions are, it tells you correlations and information about how the relationship is. It's like in my class, I talk about why we do estrone levels, why we measure estrone. Well, the reason why we measure estrone is because if estrone is higher than estradiol, it puts you at a 60 to 90% increased risk of developing type 2 diabetes. It's not my say-so. Framingham out of Massachusetts came out with a subpopulation and found these males with higher estrone levels than estradiol had a 60 to 90% increase occurrence of diabetes.
Well, it's putting it all together. It's not just A1C, let alone your fasting blood sugar. Right. It's leptin, adiponectin, some of the other metabolic brain. And what we love, by the way, at the DNA company about this battery of testing you're doing, people have to understand this is an amazing follow-up to our already highly appreciative of the role in functional genomic pathways, hormones that play, this downstream effect and have this, very intricate, very orchestrated pathway. And by the way, folks, this is not the story of XX or XY. This is the story of whether you're a male, there is a spectrum from androgen dominant through to estrogen dominant and somewhere balanced in the middle. Same with women. But what we appreciate is hormones start at pregnenolone, DHEA, from cholesterol, moving into progesterone, turning into testosterone, turning into DHT, as you mentioned, then getting expelled by the body, turning into estrogen doesn't happen without testosterone. Basically, it's a little oversimplified. But then even the downstream, which we also spoke a little bit about off mic, the downstream metabolism into the sort of more, let's call it safe for simplicity purposes, to less safe 4 and 16 hydroxyestrogen. And then what your body does to detoxify these. When that's amok, it's going to tell a story, and these ratios tell a story. So genes don't change. Your DNA is set in stone. Mom and dad gave you the genetics that you now own, but you can modify genetic expression. And when you do so through diet, lifestyle, nutrition, proper sleep, et cetera, then you can check Dr. Gordon's panel for all of that he looks into and overlay it on our DNA. and make sense of what's happening now, vis-a-vis how you're genetically designed, vis-a-vis how you're expressing in the moment live. So, and by the way, I want to come back just real quick, full circle with the ApoE. There's this sort of evolution, because I teased it, but this evolutionary factor that at one point it was favorable to have
Yeah.
the 4 variant. I mean, it was just your immune system was hypervigilant. You would recover faster if you were in the savannah and stepped on a sharp object versus now. But we didn't live very long in those days. So
No.
expressing the 4, right? 3444 didn't succumb to brain disease like we're seeing now. And by the way, BDNF, crucial for brain neuroplasticity, as you know well about. And also, we'd be remiss if we didn't at least sort of touch lightly on, especially in context of Alzheimer's disease, brain inflammation and the body's
Mm,
ability or desire to reduce that inflammation and heal. Detox pathways and methylation pathways, these are key players, and
yes.
personalized hormone optimization actually helps to support these genetic pathways to indeed promote better brain health, right? That's what you're getting at, is this.
Right. There's a transmembrane transporter called neprilysin, which is responsible for getting out of the cell the accumulating beta amyloid. And what stimulates or what hurts it is inflammation. What stimulates it is estradiol and testosterone. Pregnenolone, progesterone, all are neurosteroids, help to upregulate the ability of the intracellular beta amyloid to be taken out.
Right.
Okay. Um, I have a slide, an animated slide. It took me about a week to put together, which walks you through how the process occurs, where understanding that the foundational protein that they call the amyloid precursor protein, which is a large protein that could be snipped or cleaved. Over here, it gives you beta amyloid, which generates the inflammation that we end up calling Alzheimer's. But it can also, with 2 other enzymes, alpha secretase and gamma secretase, cleave another area that's inert. So the question arises of, okay, we've got this enzyme system that can cleave the amyloid, the Alzheimer's precursor protein is another name that I call it, in either an inert or dangerous area. Why is it preferentially doing beta amyloid? Well, it turns out that the enzyme that regulates it, the alpha secretase, is zinc dependent.
Mm-hmm.
So if you're zinc deficient, also the neprilysin is zinc dependent.
And a
So
lot of
you've got,
people actually get in this trap, by the way. Sorry to interject on you, because I want you to
no,
finish that thought, because
but
folks should be asking their even general physician, their GP, about doing a zinc copper ratio test. Very
yes,
easy to garner that serological evidence as to whether, and often that ratio is off and or zinc is deficient, and it's
right,
entirely reliant, similar to how we preach at the DNA company about superoxide dismutase being a
right.
manganese driven gene, which of course is often a problem when it comes to trace mineral deficiency as well. But
Manganese.
zinc is so important.
Yeah, it's about 300 processes in the body, anti-Alzheimer's, anti-cancer, because it is also the ion needed by our P53, which is the strongest,
Right.
theoretically, the strongest intranuclear anti-cancer
Cancer,
product.
right?
And if you're
Right.
zinc deficient, and according to if you believe the World Health Organization, about a third of the planet are zinc deficient in a study that they did over 10 years ago.
Yeah.
So we're running around with zinc deficiency. That zinc also blocks the ability of the injected mRNA from COVID or SARS viruses to go and replicate. It's called replicase. Well, zinc inhibits it. And you use quercetin to get the zinc into the system, or EGCG from green tea, or there's about 5 other products that you can use. But
Sure.
it's about augmenting your zinc in your cell, which is mandatory, like magnesium. So important. Magnesium,
Right. Well, and I
manganese.
was just about to say, I feel like the limelight has been on magnesium and vitamin D, of course,
Yeah,
irrefutably, for just so long. It's, considered, and yes, of course, they each control respectively many hundreds, and or are related to, when there is a limit. They're limiting factors. When you're deficient, everything falls apart. But
right.
some of these trace minerals, I think for so long we've also been over focused on, multivitamin. And I
Mhm.
think if anything, we probably missed the boat on being initially focused on multi-mineral before jumping into, I mean, listen, the B complex, we can
Yeah.
get into that and all these other, I think vitamin A is another one. I think that's actually next, decade will probably become, because it's third world country deficiency already, but more and more we're seeing this fat soluble vitamin B deficient in a lot of folks. And boy, our immune system falls apart, brain health falls apart, skin, aging, accelerates, et cetera. So your groundbreaking work clearly with TBI, traumatic brain injuries, changed the recovery landscape for so many people, and the use of the plethora of master hormones down through to hormonal metabolites is game changing, right? So there's this long term
Absolutely.
link between TBI and increased risk of Alzheimer's. And of course, hormone therapy, when appropriate, either brain centered or downstream. And we're talking also about neurotransmitter hormones. We're talking also about thyroid, not just steroidal like estrogen, being estradiol, estrone, estriol, et cetera, and even testosterone for guys. But you've mentioned the critical role in your work anyway of growth hormone in brain
Right.
repair and neurogenesis. Can you explain why, stick on that for a second, why low
Sure.
growth hormone levels can severely hinder recovery from TBIs, and even how this relates to Alzheimer's?
Well, let's talk on Alzheimer's. Alzheimer's is being called type 3 diabetes.
Right.
Okay. So I have a short paper that I just wrote on this. And what happens is when there's neuroinflammation, what hormone do you think gets nailed and downregulated in the brain from inflammation? Growth hormone.
Right.
So what happens is when you lose growth hormone, you also lose something called IGF-1, which stands for insulin-like growth factor. So what happens is inflammation drops a special transport molecule that takes sugar from outside the nerve to inside the nerve. We call it the GLUC4 receptor. So the GLUC4 receptor is how sugar gets into the cell. You need to have chromium and you need to have insulin in order for that to happen. Well, because of the inflammation, that GLUC4 receptor is not working very well, and insulin is not working very well. Well, why do they call IGF-1 insulin-like growth factor? Because it crosstalks with the GLUC4 system about 10% sensitivity. So, growth hormone will help to increase the transport mechanism for sugar getting into the brain. Okay, that's number one, probably one of the most important ones. A second one is we talked about in all these neurodegenerative diseases like Alzheimer's, Parkinson's, multiple sclerosis, ALS, that there is a breakdown in the glue that holds the microtubules together. That's the tau protein. Well, it turns out that growth hormone has been documented to help rebuild these microtubules. So the importance of the microtubules, which is a transport tube, like a subway from the body of the nerve to the axon, the tail end, it transmits the neurotransmitter acetylcholine. And that is the key deficient neurotransmitter in Alzheimer's disease. So it helps to rebuild that conduit, that transport tube, to improve that. Another aspect of growth hormone is its um, microglial or inflammatory modulating. It modulates it by quieting down the microglia. Another hormone that does phenomenally well for that is vitamin D. Vitamin D helps to stabilize the
Huge.
hyperactivity. And that's why we see studies where people with autoimmune diseases, with chronic asthma or allergic conditions, that by being on healthy therapeutic doses of vitamin D, you get a drop in the inflammation. I mean, you go to Google Scholar and you put in vitamin D plus whatever, you see all
Yeah.
these articles. I mean, there are 1.37 million articles talking about vitamin D protecting you from COVID.
Well, and I know this is nomenclature, so I don't want to stick on this too much, but
Yeah,
it's a vitamin that should really be reclassified as a hormone,
correct.
right? Yeah.
Yeah,
It
it's
plays that role.
Yeah, it's a seco hormone. Anything that comes off a cholesterol molecule is called a seco hormone. So
Right.
testosterone, pregnenolone, all that stuff. Also CoQ10, the ubiquinines, ubiquinols,
PQQ.
the PQQ, which is phenomenal for brain health. Just it's what 100
Well,
to 1,000 times stronger than CoQ10.
right. And most people don't realize this, but and I heard you talk a lot about this in your work and seen it. Mitochondria, of course, which play the role of manufacturing the currency of energy in our body, the ATP we all need, not just for our muscles to move and our brain to think, for the cells to do their job. By the way, we'd probably be very remiss if in context of this conversation or part of the conversation that we didn't remind folks on the importance of getting up to red blood cell saturation of omega-3s. I mean, this is the work of Dr. Bill Harris and Omega Quant. Love those guys for their test capabilities. So easy to use at home, little finger stick test, but it'll tell you when you're optimally saturated for omega-3s, and that, DHA, docosahexaenoic acid, being so important for the brain cell malleability and for vitamin D to even do its work, let alone maybe increase its uptake. Right.
Right.
So omega-3s are absolutely imperative. But I guess what I was getting at was, as it pertains, at least anyways, to some of these higher brain center hormones, and particularly growth hormone, and particularly the releasing hormones, of which there are many, that has this action on downstream estrogen, testosterone, and that whole role of cognitive stability. It's now kind of irrefutable, right? And folks need to understand that testing for not just one or two things to determine where they might be in their perimenopause or menopause, but in context of keeping a healthy brain, which we like to call brain span, right?
Yeah.
Managing a healthy brain over time. And it involves all these hormones. It involves all of these neuroprotective vitamin mineral markers. By the way, I want to ask you, have you heard of that marker, which also fits into this, insulin-like growth factor story, leptin, adiponectin, cystatin,
Right.
and so forth. But the one,
Carolyn.
no, the 1,5, it's that position 5 anhydroglucositol, which is kind of
No.
like it's like A1C is remarkable for its ability to predict 3-month sort of term, glucose over time, glycosylated to the hemoglobin, right? But this, I think it's called glycomark. It's TM'd, or the IP is glycomark, but it's this more of a short-term predictor. So it's
Mhm.
more of a sort of month and a half predictor of where your blood glucose level is, even when A1C levels, by the way, are optimal, right? So low levels of this glycomark specifically indicate extreme episodes of hyperglycemia, more than 180 or so, 200
Right.
milligrams per deciliter over the last couple of weeks. Anyway, I just thought I'd bring it up because when you're not managing insulin, and or it's insensitive, the sensitivity and blood sugars getting its way, this is an impetus for inflammation, which is again the sort of theme of what we're
Yeah.
describing. What
Yeah.
about toxins?
About
What about toxins and
oh
neuroinflammation? I mean, I know you've also covered how environmental toxins and viral infections, and you brought up COVID, which we don't have to be so secretive about anymore, because the evidence is in. It's in. But
But people are
viral
still getting
infections,
the vax.
right? Just don't get me started.
Okay. I
Because then they'll
just got
cancel this
started.
episode. But infections, including COVID,
Yeah.
exacerbate neuroinflammation. In fact, if anything, maybe even cause it. And now we know genetic predispositions make certain people more vulnerable to certain toxins. But how does hormone therapy counteract this vulnerability?
Well, the foundation is that these neurotoxins damage chemical pathways within the nerves by inflammation. I mean, these are particles of chemistry that the body looks at and says, this is a foreign substance. Turn on the immune system, drop
Right.
pro inflammatory cytokines, get tons of it. What do you think's happening with the spike protein? Spike protein gets into the body and it triggers a chronic inflammatory process in our entire body. Well, the brain is part of the body. And what they found is that, yes, the spike protein gets into the brain. The spike protein is in a compendium of articles I have, the spike protein is responsible for inflammation that shuts off the gonadotropic releasing hormone from the hypothalamus. So you can't make luteinizing hormone, so you don't have hormones. And that's why we're seeing such a rise in infertility,
Right.
such a rise in hormone deficiency in males. 20 years of age, 24 years of age, having levels that I've never seen before, except in people who are either dead or nearly dead, where they don't have any hormone production. And the literature clearly states the inflammation. Then back in 2013, a whole slew of articles started coming out talking about how astrocytes, which are a cell in the brain that help the hypothalamus to generate its gonadotropic releasing hormone. So what happens in the astrocyte is the inflammation alters it from a healthy state to an activated state, which is dumping all these nasty chemicals which shut off the hypothalamus. So it's a little bit more convoluted, but the point is inflammation disrupts a multitude of pathways. You get a cold, how come your memory goes? Because it influences the NMDA, which is a cell receptor in the brain, which is for long-term potentiation, which is a big name or big term for memory.
Right.
It's how it ingrains your memory. And when you disrupt that, you're trying to remember things when you got a cold and you can't. When the cold subsides, your memory's back. Or else you go and play hockey and get hit by the puck. You get pucked in the brain and you're, disoriented. You have a concussion. You're confused, nausea, vomiting. This is all inflammatory processes in the brain. Right. As it subsides, you get better. Or if you do things to accelerate the correction of the inflammation is the key.
So I want to unpack this a little further, especially in context of, cytokines, because this does describe and help people understand immune modulation. It's not a fancy term that we use because we think, our lexicon of herbs does such a great job, which it does. And these antioxidants, quercetin, you mentioned DGCG, but the name of the game is immune modulation because we've got these pro and anti-inflammatory governors, right? Called cytokines. Right. And by the way, throw in there, because I know that you love talking about fractalkine. This is part of that story, right?
Excuse me? You said what to me? Fractalkine?
Yeah. Did I get you started now?
Yeah. No, I was holding back on that one.
Oh, were you?
Because it's fractalkine, if you'd like, fractalkine is a chemical that's it's a chemokine. It's in part of our immune system. It's
a little different than a cytokine.
System made by neurons. And what does it do? It tells the immune cells, stay cool. Don't turn on. Don't activate. Stay cool. And so you've got a regulatory system that tries to protect the brain from hyperactivity or overaction of the inflammatory producing cells, the microglia, our immune cells, just like the white blood cells below the neck, leukocytes, lymphocytes, monocytes, and so forth. And so what happens is under stress, 100% stress, forget any kind of bodily trauma, under stress, what happens is cortisol goes up. Cortisol shuts off the neuron's production of fractalkine. So what happens is the cells now are able to convert from this sedentary, quiescent, quiet state into this activated state. They call it M1 state. And it has the capacity to start dumping all these pro-inflammatory cytokines. So cortisol will increase the inflammation. So in people who have that term they use called PTSD, it should be 100% stress related, no history of trauma. But in a study we did last year on our military, it turned out that every one of the 79 veterans who came into this study, that everyone had a diagnosis by the Veterans Administration of PTSD. And when we asked them directly, did you have any traumas prior to enlistment in the military, during enlistment in the military, or post? Every single one did.
Right. The re-traumatization effect. It does predispose you for second round, if you will. Right.
Yeah. And then there was a brilliant study where they looked at women who had fractured a long bone, leg, femur, so forth, tibia, fibula, below the knee and between the knee and the hip. And they looked at the menstrual cycle. And what they found was the menstrual cycles went off. And what was that due to? Well, any kind of trauma increases cortisol, decreases fractalkine, increases the ability for inflammation in the brain. That inflammation shuts off their hypothalamic regulation of their menstrual cycle. No head trauma, stress, but a physical stress from a fractured bone.
And that's the body's way. I mean, that's homeostasis, right? Saving and being, subconscious. Your body is working subconsciously, so it doesn't necessarily involve the brain all the time or deeper levels of the brain to make sure that there's reserve. Save the menstrual cycle for when we've got enough homeostasis
When you're healthy.
going on. Yeah.